morning, everyone. The step doesn't seem high enough, but I'm going to try my best. Thank you so much for the invitation to present here today. And I think listening to the previous talk, we can all agree that administering ARVs to neonates reduces HIV transmission, both intrapartum and postpartum. But where you are born in the world depends and influences the choice of ARVs you receive for infant PNP, as well as the duration. A lot has to do with what are the drugs available in your country. Do you follow a risk stratification policy with high-risk infants receiving something different from low-risk infants? Do you treat term babies and preterm babies the same? The answer is probably no. And then what are the feeding practices also? And do you support breastfeeding? So, as mentioned by the earlier speakers, we probably have the most information about nevirapine, zidovudine, and 3TC oral liquids that have been used for many years for infant prophylaxis. They are very effective, but they also do have some problems. For example, nevirapine has got quite a low resistance barrier, and it's the only drug where there's a different dose being used for prophylaxis versus treatment, complicating dosing strategies for clinicians and mothers. Zidovudine, the first drug ever studied, probably has the most preterm PK data, but if you use it for a long period of time, you get transient anemia and neutropenia, which is definitely not ideal, especially for a preterm baby. And then 3TC we've mentioned as well, which is a relatively safe drug. But I think we are now moving into an era where we have better ARVs. There's been a lot of advances in neonatal HIV care, birth HIV PCRs being phased in. The importance of early ART is appreciated by people. And I think it's time that we start considering adding the newer, more potent and safe ARVs as alternatives for infant PNP. I'm not going to spend long on this slide because I know Elena's already showed the new guidelines. But what I would like to highlight is there's been a shift from the 2021 guidelines, mainly focusing on either nevirapine or a combination of nevirapine and zidovudine, to now also including DTG and 3TC as alternatives in the for low-risk infants, as well as infants that are breastfed. And then, as Ted mentioned, we've now moved to recommending a 3-drug ARV regimen for high-risk infants. But where is this evidence and this move to change coming from? So lots of this started in 2021, where there was a series of workshops hosted between Impact and the WHO, looking at strategies for infant PNP and how can we get closer to eliminating HIV. And one of those workshops also included the Padova meeting. So within that workshop, it was DTG in neonates was prioritized as one of the key research gaps that needs to be studied. We were very fortunate at the time to already have an established petite platform running, which was assessing solid ARVs in neonates through PK and safety studies. And this is a collaboration between Stellenbosch University at FAMCRU and also with Tim Cressy in Chiang Mai. And with the support of UNITAID, we were given some extra funding to actually develop and design the petite dolutegravir study. And for this, we were going to investigate 2 dolutegravir formulations. The one is the generic 10 milligram scored one that's widely rolled out. And the other formulation was a novel oral dispersible film, which was used for the first time in children. So in the planning stages of thinking how are we going to study DTG in term neonates, we obviously need a drug formulation that can work. This was problematic because the lowest dolutegravir dose is 5 milligrams, and this is recommended for daily use in infants more than a month and 3 kilograms. And we were very worried whether this would be suitable for neonates. Neonates have got much more immature livers, and we were concerned that if we were to give 5 milligrams every day to a neonate from birth, that we would see very high exposures and toxicity. So for that reason, we looked at this formulation to first see if can we give a fraction of this dispersion. So we did an in vitro experiment locally at Stellenbosch University where we took 5 milligrams, added it to 5 moles of water, and then did different swirling experiments in the lab. And then we sampled from the top zone, the middle zone, and the bottom zone in the lab tube. And you can see on the graph on the right-hand side that the top and the middle zone, basically there was very, very little drug. Everything just sedimented to the bottom, and there was no uniform dispersion, which basically said that it would not be a good idea to try and use it like that and administer it to a neonate. So therefore, the only other option, if we were to use DTG in neonates, was to come up with an alternative dosing strategy, which could be either every 72, 48, or 24 hours, and we were not sure at that stage how it would pan out. At the same time, there was also a 5 milligram DTG form that was manufactured by Loris Labs in India. They also have a 10 milligram form, which received a tentative FDA approval, and we had the opportunity to incorporate this DTG film in the multi-dose stage of the PETITE study. So just very quickly, what was the study design? So we were very cautious and careful for the safety. So we first just gave a single dose of 5 milligram DTG dispersible tablet in week 3 and 4 of life. When there was no safety concern, we were quite happy to move that earlier to birth. So the second half of that cohort actually received 5 milligrams DTG closely after birth. There was no safety signal, so we used the PK data from that, performed modeling and simulation, and came up with this multi-dose strategy. We were going to give 5 milligrams every second day for the first 2 weeks of life, followed by 5 milligrams every day in week 3 and 4 of life. So this strategy was then taken forward into stage 2, and the babies were randomized to receive either the DTG dispersible tablet or the film. We had 43 babies enrolled, and 22 of them received the dispersible tablet and 21 the film. As this was quite a novel dosing schedule, we did spend some time in the study to also explain to mums how to give this drug and to be able that they don't make mistakes. So what we came up with was a diary card, which basically had black-gray lines zoned out on the days that they were not supposed to administer the drug. And then obviously they wrote the time and if they were given the dose, and if they didn't, why not. And we looked at it afterwards, and we were very, very happy to see that our mums actually did very excellent with this new DTG dosing schedule. Only 1% of the doses were outside of the window in the first 2 weeks of life, and only 7% in week 3 and 4. Obviously, we realize this is a study, so it's not necessarily reflecting the real life, but it does show us that it is not impossible for our mums to administer DTG in this way. So looking at the PK and the safety, and this is just the concentration time curve showing the exposures of DTG both for the dispersible tablet and for the oral form. And one can appreciate that they were very similar. None of them exceeded the upper target, and the geometric mean was above the lower target that was set. With regards to the safety, this was also very supportive of administering DTG in neonates, term neonates. And none of the AEs that we observed were related to the study drug. We were very worried about the theoretical risk of physiological jaundice. I'm very happy to report that only 3 of our babies presented with jaundice, all of whom which spontaneously resolved. So the conclusion from this study was that this DTG dosing schedule met the targets and that it was safe for both of these formulations. So just switch quickly to abacavir and just mention that before 2021, there was actually no abacavir dose recommended for term neonates. So together with the Impact Network and some studies that we performed within the Petite platform, we pulled PK data from 3 studies, and we developed an abacavir weight band dose for the liquid that was subsequently taken up in the guidelines, as well as an exact milligram per kilogram dose. Following that, we had the opportunity to look at a fixed dose combination of abacavir 3TC, also in term neonates from birth. We gave a quarter of this tablet every day, and what we noticed was that the exposures were very high, especially in the first week of life. At that stage, or subsequent to that, when we realized that the dolutegravir was going to have to be given every second day, we thought it would be good to just explore a little bit with modeling and simulation whether it would not be more beneficial to actually administer the abacavir 3TC at the same time as the DTG, and then come up with a regimen for solid formulations for the first month of life using abacavir 3TC and DTG. But what about preterm infants? So here we really lack data, and I'm sure many of you agree that a lot of the decisions we make for preterm infants are based on expert opinion. We do have data, PK data, on zidovudine, nevirapine, and 3TC, but most of these data doesn't really go below 34 weeks. So that very preterm infants is still a huge research gap. So the WHO and Impact prioritized looking at this, and we combined 8 neonatal and infant PK studies and proposed a 3TC dosing for very preterm infants that was simple and easy to follow. However, this still needs clinical validation before implementation. Of course, the next step would be, can we look at dolutegravir in preterm infants? And that's something that our group is actively pursuing at the moment. A problem here would be the DTG formulation, but there is a possibility that the film can be manipulated, and we are currently investigating that. And then just to highlight that this dose for DTG in term babies that we're now recommending should not be extrapolated to preterm infants who have much more immature livers and higher risk of jaundice. So this brings me to CAB. So what can I say about that? Fortunately, it made the list also to the Part 5 meeting in 2021. And what is really exciting about CAB long-acting is that this is one of the few situations where we have the drug ready to use. With neonates, we always have to try and see how can we adapt an existing pediatric drug. But here we actually have the drug available. We just need to figure out how to dose this drug. And there's obviously potential challenges. There's a very slow maturation rate in the liver. An infant double their weight by 6 months and triple it by a year. The muscle mass is not well developed, and no one is sure how the drug release rate is going to be. And then, of course, there's a huge role here for modeling and simulation to establish the initial dose. And then it is part of the integrase inhibitors, which have good safety, but have not really been used that much yet in neonates. So we will have to follow a very cautious approach when investigating this drug. But some good news to share with people is that there's definitely movement and action, and because of many people in this room, and it does. And VIF is planning a PK and safety study of CAB-LA in term neonates, which is currently in the protocol development phase. So just quickly, long-acting agents, and I'm not going to dwell on this, but there's definitely a role for this in future. I'm not sure if we're quite there yet with regards to passive immunization. And what we would really like to have is a combination of BNABs with good potency and good breadth. And then, if I can quickly pretend I'm Harry Potter today with a magic wand, I would like to share my wish list with you for neonates going forward. So for term babies, I really think if we could give CAB and through the breastfeeding period, it would be a game changer. There's definitely a role for BNABs, although I don't think we're quite there yet as to know what to give, and should we give it alone or should we give it in combination with ARTs? And hopefully, when we perform the study with CAB, we will also learn a lot of things that we can take forward, and who knows, maybe one day we will be able to give LEN to babies for PMP. Then for preterm babies, something I'm quite passionate about is to develop an easy preterm dosing table for the 3 commonly used drugs. So a table with not too many step-up in doses, trying to do the step-up in doses at the same times for the different drugs, and actually just try and see if you can prevent drug error, which is quite difficult with this population. I think if we can give DTG for preterm infants, it would be excellent if they can have access to a potent, safe drug like DTG. And then, of course, the safety of BNABs is very alluring for preterm infants. And also the fact that it doesn't affect, or the physiological maturation does not have an effect, and one can potentially administer this IV in a baby who already has an IV line. So that would be my wish list, and with that, I would just like to thank everyone.